So good morning, good afternoon, good evening, everybody. My name is David Collins. I'm with Boston University School of Public Health, and I'm with Colin Gill-Martin from Management Sciences for Health. And we are here today to talk about a tool that we developed when I was also with Management Sciences for Health, called the Community Health Planning and Costing Tool, which was developed together with UNICEF. So the title of the session, should be on your screen, is Costing Community Health Services, with the objective of providing evidence to support improved planning, resource mobilization, and health outcomes. The objectives of this session are to provide participants with an understanding of the costing of community health services using the Community Health Planning and Costing tool, and the use of the results to prepare investment cases. In this session, we'll mainly provide an overview of the tool. In-depth training on the use of the tool and the preparation of investment cases will be provided at a later date, so interested participants can contact Dines at JSI or I think any other member of the organizing team. So today we're just really providing an overview of the tool itself. The Community Health Planning and Costing tool original version was produced in 2017, I think, and this is version 2.0, which was published in 2020. The original version was used in quite a few countries. Colin led many of those studies in the field, places like South Burkina Faso. The new version of the tool has been translated into French. It has preloaded standard treatment guidelines to reduce data collection. It has a video tutorial and a handbook, which you can find on the MSH and UNICEF websites, and it has an embedded user guide. And it's a menu-driven tool. And you can see the diagram underneath there showing the different symbols that are used for the different aspects. And we'll look at this when I go into the tool. So the functions of the tool are kind of two. Excuse me. The user can enter baseline figures, which are the actual numbers of services and the actual expenditure in a baseline year, and then enter 5 years of projections, which can then be compared with the baseline. Those projections start off with target numbers of services, which are based on incidence and prevalence rates and kind of targets that can be achieved. Those numbers of services are multiplied by normative direct unit costs. To those is added normative indirect costs to get total normative costs. So you can compare the target numbers of services with the actual numbers of services, which will give you the scale-up targets, and you can compare the actual expenditure with the normative costs to find out your additional financing needs. Just to explain a minute what we mean by normative costs. Normative costs are the costs that the service of providing the service in a good quality way. So it assumes that the community health worker has sufficient time to provide the service and that he or she has all of the equipment that they need, has the medicines and supplies that they need, and have the support from supervisors and managers that they need, so that it's a fully functional service. And as we well know, that this is often not the case in the field. So when we're comparing actual with normative, we're comparing kind of sometimes a service that's not fully functional with the ideal, a service that will be fully functional. This is a more complex diagram, and I think because time is rather tight and we want to show you the tool, I'm not going to go into this at the moment. So the Community Health Planning and Costing tool has features in it. So, for example, it has these navigation links that I mentioned before. It has embedded notes. If you see the little red triangles in the cells in the tool, so a lot of the user guide features are actually embedded in the tool. And it has drop-down menus for many of the cells that need to be where data need to be entered. So, for example, you can choose from a list of countries. You can choose Malawi, and it will populate with some data like the population and the growth rate, or from within the tool. So we tried to make this tool as automated as possible to reduce the amount of work that you have to do to use it. But anything in the blue cells can also be overridden by the user. I'm going to switch now to the tool itself. Just give me a second. I hope you can all see this. It's on my screen. So we are now in the Excel tool, the Community Health Planning and Costing tool. This is the first page, the first sheet in that tool. You can see it's version 2.0. I apologize if the writing and the numbers are a little small. It's on 100% magnification. The problem is if I make the font too big, then you don't get a vision of what's in each sheet. So hopefully it's okay for you. So the only thing to mention from this sheet is, of course, that it's a joint tool with UNICEF and MSH, and that it's an open source tool. So the user can change anything in this tool, but you have to be careful, because if you change the structure or the formulas, it's quite likely it's going to result in errors. This is the main menu for the tool. It's menu driven. So you can go to by pressing any of these buttons, you can go to the sheet, and you can then return quickly to this sheet and move to another one. It has the cells, the sheets have different color codes. So you can see here that these dark green ones are data entry sheets. These you need to enter data in, and I'll show you these as we proceed through the tool. The light green underneath are already preloaded data, although you can override them. The next section down below are the brown tabs, which are the results tables, the results sheets. And the dark blue ones down below are intermediate calculations. You don't need to do any data entry. You don't even need to look at these. But if you want more information on how the costs are calculated, you can go to these sheets. There's a feature down below where you can protect or unprotect the sheets. We recommend protecting the sheets if it's an inexperienced user, because then that person can only enter data in the data entry cells, and they're unlikely to have problems with the formulas by changing formulas. As I mentioned, there is a tool use and data entry guide embedded within the tool, as well as a separate user guide, which is in a booklet form that you can download from UNICEF or MSH. And this just explains how to use the tool, how to enter data, etc. This is the diagram that I showed you before in the slide. As I mentioned, we're not going to go into it because I want to allow enough time to show you the tool itself. So we start off, there is here a sheet which shows you the data that you need to collect to populate the tool, and where you can generally get that information from, both primary sites and secondary sites. So you can use this as a planning feature and also as a checklist to make sure that you've got all the data that you need. This sheet allows you to configure the tool, and it has it gives you the ability to change these features, whether you want to use the preloaded data, yes or no, whether you want to run a list analysis, the bottleneck analysis, which we'll explain briefly, whether you want to use the financing sections, and whether you want to show or hide different sheets, such as the intermediate calculations, etc. Each of these is driven by a drop-down menu, so you can just change it in the way that I'm showing you on screen. The next sheet is the program data sheet, and here's where you would enter the name of the country, the baseline year of the analysis, the population for the country and the population growth rate, the currency and the exchange rate and the inflation rate. And excuse me, down below you have, if you're doing a sub-country analysis, like one region or one district, then you can enter the population of that district. In this case, as you can see, it's Kigoma in Tanzania, this example. This is not a real life example, this is just dummy data. You can also work separately, do the analysis separately for rural populations and urban populations, because sometimes they have different packages, and this will allow you to do that. And you can enter data such as the household size. I'm not going to go into all of the cells on each of these sheets because it would take too long for this session. So I'm really just giving you kind of a snapshot. The next sheet is the program structure itself. And here you can decide how many community health workers there will be, because in some cases there are different types. In this example, there's only one. How many supervisors there are. In this case, there are 2 different kinds of supervisor. And how many managers are involved in managing the community health worker program. And then depending on your answers to this, then you're able to fill in down below in the blue cells, which are the data entry cells, the title of the community health worker, the desired ratio of population, the attrition rate, and different important things like the numbers of working hours per day, how many days per week, how many weeks per year, how much time they spend in training and meetings, etc. This is important because the tool calculates how much time community health workers have available to provide services. And that is very important because when you're setting targets for how many you want them to reach, this will allow the tool will tell you if you are exceeding their ability to provide the services. In other words, that you're expecting them to work more hours than they actually have available. The section down below is showing you the annual community health worker salary and any performance-based incentives and salary increases. Excuse me, I have a lingering cough post-COVID, which I caught recently, and it's annoying. I apologize for that. So the next section down below is supervision, which gives you the 2 different kinds of supervisors, how much are their salaries, and how much time they would spend on supervision. So this gives you the costs, will end up with the cost for supervision. And finally, down below, you have the management section, which shows the different kinds of managers who are involved and how much time they will spend and what are their salaries. So these will give you the indirect costs of supervision and management, which can then be loaded over the direct costs of the services. The next sheet is the preloaded package. As I mentioned, that the first version of the tool was basically blank. You entered whatever package was for the country, which varied by country. But people felt that it would be useful to have a preloaded package that they could already start working with, because many of the community health services are the same across different countries. So here you have the preloaded package. You can see that the top few are maternal and child health, such as antenatal care, postnatal care, ICCM, etc., etc. You can then check on this column which says include in the package, and this allows you to say, yes, I want to keep this in the package, or no, I want to remove this from the package because it's not in the package for Tanzania. And here it's in the second column, it's asking you which CHW is going to provide the service. In Tanzania, in this example of Tanzania, there's only one type of CHW, but in another country, there could be two different types, and then you can choose which one. In this example, there's also the user has also entered other services which are separate from the preloaded package. So by putting them into these blue cells under custom intervention, and these are listed below. And again, you can say yes or no so that you can play with this. For example, if you find that the package is more than the funding that's available, you could say, how much will the cost be reduced by changing one of these from a yes to a no, because that will then take the costs out of the package costs. The next sheet is program scale up. And
David?
yes.
David, sorry to interrupt. You have a couple questions in the chat box. I don't know if you're planning to take questions now or wait till after.
I prefer to take questions at the end because it will take quite a long time to go through.
Okay.
Okay, thank you. This sheet now is program scale up. This is showing you the population that you started with in 2018 for Kigoma, and then applying the population increases according to the percentage. This doesn't take into account movement of populations such as migration or refugee populations, but you can change these figures yourself manually. All of the figures in the blue cells can be changed. And down below in the section underneath, it's showing you the numbers of regions, districts, villages, and hamlets within the community health worker program. So you can expand, you can use this section to expand the population itself who will be covered, but also the number of districts that will be covered. So, for example, this could go from 4 to 5 to 6 districts, which would automatically give you an increase in population, or you could be just increasing the number of population covered within the same number of districts over time. So you can play with it, kind of geographical expansion or utilization expansion within this section. You then have the this sheet where you can set coverage targets for each service. So here are all of the services that are listed, which are driven from that preloaded package sheet. And you can see, for example, in the first one, antenatal care, the actual number of services in 2018, which you would enter. Here, 31,000. The expected numbers of services based on the numbers of women in this population who are expected to become pregnant at that time is much higher. So the coverage is only 25%. So you can then use these figures to set the coverage targets on the right-hand side, which you basically just enter manually. So in this particular example, it was decided that the coverage would stay the same in 2019 and then would increase to 35% in 2020, et cetera, et cetera. You can see in this particular example also that this is just a 4-year expansion model. The 5th year has not been included, so 2023 is blank throughout the tool. The next section is equipment, and this section you can enter the equipment that is required for the community health worker. down below for the supervisor, and further down for management. So this can be as detailed as uniforms, raincoats, etc., etc. How many units per community health worker? What is the cost of each one? What's the initial year of purchase? And when they should be replaced. So in this example, you can see the replacement figures are zeros. In other words, they don't need to be replaced over the 4 years, except for one, which is non-sterile gloves, which would need to be replaced every year. So this gives you a lot of control over the equipment. And as I said before, this is normative costing. So this is not what they actually have, but what they should have in order to do their work properly. There's a section on training that allows you to enter all the training needs for the program, whether it's initial training in the first year of a program, or whether it is refresher training, which would be done every year. The next sheet is supervision management, in which you enter the number of visits that would be made by supervisors, and whether, for example, they're made to the village level or down directly to the hamlet, which is basically the individual community health worker. And you can then enter the costs of those in there, and it will calculate the supervision visits. This example is not fully populated with all of this information, and that's why it's blank there. You also have meetings that you can enter in this section, whether they are supervision or mentorships or other kinds of meetings. And you have a section for other recurrent costs. In this case, it's batteries for scales. And you have a section for startup costs for capital costs, such as buying scales themselves. And again, you can put which year they're incurred in and how much is the cost. So we've finished with entering the cost now. By the time we get to this stage, the next sheet is on the financing. So this is an important sheet where you can do your best to fill out how the money is going to come from to pay for the program. Some of this may be already committed monies, and in which case you can enter it here. And once you've entered the funding that you already know about, then you will automatically know the gap. What is the shortage of funds for the program? So here, for example, it's giving you percentage to say that UNICEF will provide all of the equipment in 2021. In 2020, it'll only provide 49%, and the balance will be funded by the Embassy of Ireland. So this is very helpful for modeling the sources of financing and allowing you to determine the gaps. This is a sheet that gives you all the information on this preloaded package, and it's come from the different sheets previously. So most of this is not a data entry sheet. So you have here, for example, antenatal care, which program it fits under. By giving it a program, that means that the costs can be summarized by program. So it doesn't just give you the cost for antenatal care, it gives you the cost for the maternal and newborn health program as a whole as well. It shows the target population, pregnant women, what kind of service it is, preventive, curative, campaigns, etc. And this allows the results to also be summarized by service type. So you would know what is the total for preventive services, curative services, etc. It gives you the provider, the community health worker, and the episodes or cases per target population. So in the costing, what it's costing for antenatal care is a standard of 4 visits per woman per pregnancy. Again, these are standards, but you can change these if you need to reflect different norms within a country. And here underneath, you can see these references. So on the right-hand side now, you can see a reference for the service to note 1, and a reference on incidence and frequency, note 4. And then down below, what you have is an explanation for each of these, for all of the notes and for all of the, and also for separate ones for family planning. So there's a lot of information already in the tool, which means that you don't have to go outside the tool necessarily to look to see where these figures have come from and why they've been done like that. The next sheet is the preloaded medicines and supplies. So each service, if there are medicines involved, the cost of the medicines is automatically calculated, and it's drawn from, the price is drawn from this sheet here. This is populated from the UNICEF supply category, or from WHO, or possibly from the older MSH drug price indicator guides. So again, these are standard prices, but you can change these if you need to. This is a very important section. So I talked about the normative costs when we came in. So this is where the normative cost of providing a service is set out for each of the services in the package. So for antenatal care, you can see here that the time estimate required is 33 minutes. So if you have once you've set a target for the number of antenatal care services, it's going to multiply that target by the figure of 33 minutes. And it's going to say this is the total number of minutes required to provide antenatal care to this target population of women for the month or for the year. And as I mentioned earlier, it will then, as you go through all of the services and you calculate all of the minutes required, it will tell you if the community health workers have sufficient minutes to provide those services, or if they don't, which would then mean that you either need to have more community health worker time made available, or you need to reduce the target for antenatal care. So the number of minutes is very important, and as Colin will mention later on, it's one of the more difficult things to estimate for community health workers. Also in this section, you would enter the numbers of the types of medicines and supplies, and these are drop-down menus, so it goes over to the list of preloaded medicines that I showed you a little bit earlier. You would enter the number of times per day, the number of days that this medicine is given, the number of cases treated, and the units per dose, and then it will automatically calculate the cost. So these two things are the normative costs of providing one antenatal care visit, and it says the same, it has the same for all of the different services in the package. We are then looking at the summary tables here. So these are now the results, and there are many different ways in which the results are laid out, and I'll go through these fairly quickly. So you have, first of all, you showing the baseline year 2018, and then the 4 target years. As I mentioned, the 5th year is blank, and that's why in certain cases you're getting error messages. They're not important. When it's populated, those error messages will disappear. So in the first section, you have the population, how much of the population is covered, urban and rural. You have the numbers of community health workers, and you have the average number of services provided by each community health worker per year. This is important. You can see here that it goes from 670 to 1356 to 1857, 2222, and finally to 2891. So you can see that each community health worker is increasing in this example, the amount of services they provide. until they get to 2022, and the warning sign has come up there because they don't actually have enough time to provide those services in 2022 because of the normative time that's required to produce each service and because of the hours that they have available to work. So in this case, for 2022, you would have to do what I suggested earlier. You'd either have to have the community health workers work more hours, or you would have to scale back the target, one of the targets or all of the targets for 2022. The next section is showing the numbers of community health services by program each year. The next section is showing them by category: promotional, preventive, curative, etc. And the next section is showing you the costs. This shows you the costs for community health worker salaries, the cost for equipment, medicines and supplies, etc., down to meetings, and then it's showing you at the bottom the total cost each year. So this is the amount of funding that you would need to find each year of the program. It shows the same figures here in the next table by percentages, so that you can see in the first year, in the baseline year, that the highest cost is 59%, which is for the CHW salaries. This is important because if you have to reduce the cost somehow because there isn't sufficient funding available, this table will show you where most of the money is going and where there is the greatest opportunity to reduce the cost. The next section is showing you the overall program costs broken down by recurrent, startup, and capital costs here. I added this in here because the red line in here, because when I was playing with the tool, I wanted to see what difference it makes if I change some figures. So these are additional things that I've added just for this exercise. It shows you the cost per capita, the cost for the total population per capita, like the whole district or the whole region, and then the cost per capita for the population covered. So you can see initially you're spending $2 per capita of this program for the population covered by the program. You also have the cost per community health worker, including also the supervision cost and the training equipment costs. And you have the total cost by program. So you can see here that ICCM starts out as being the highest cost program. But as you move over to 2022, it's actually maternal and newborn health that becomes the highest cost program. And then you have the same figures as percentages. And here, the next few sections are showing you how much funding there is available and what the gap is. So you can see, based on the entries that you made, for example, to show that UNICEF will fund the equipment, together with the Embassy of Ireland. You can see that you have gaps down here which are not covered of $102,000 in 2018, increasing to $178,000 in 2022. So that's where you would need to find additional funding. And here's a breakdown of that funding in the different areas that are uncovered. So recurrent training, there's a shortfall in that funding in 2020. And this under now is further breakdowns of the funding. So I'll leave those sections for now. All of these, or the main tables from the summary, are also shown in the form of graphs, which is obviously very helpful for presenting the information visually or preparing reports. So you have all of those options. You also have recurrent costs here. So this is taking the cost of each service, so which was $2.89 for antenatal care in 2018. And as you scroll over to the right, it shows you how that figure is made up. So 27 cents of that is for direct salary. That is the cost of the community health workers' direct time. 77 cents for medicines. $1.41 for the indirect salary of the community health worker, which is basically the downtime, the cost when the community health worker is being paid, but they're not actually providing services. This is allocated over all of the services so that that downtime becomes part of the total cost of each service. And you have other indirect costs. And then it multiplies these figures up by the quantities of services to show you for each service then how much the cost is broken down. So, for example, the salary total cost in 2018 for antenatal care is $90,000, and the community health, the direct community health worker cost is $8,496. Moving along, the last results table is actually showing you the costs of the medicines. I just scroll over to the left here. The units of medicine that are required to provide this program. So this is a kind of shopping list actually for the community health worker program in terms of the medicines. It's based on the figures that you've seen previously. So for amoxicillin, it's the numbers of services that require amoxicillin times the numbers of quantities of medicines for each service. And this comes to 450,000 tablets of amoxicillin in 2018, increasing to 1.1 million in 2022. And then using the costs that are in the preloaded medicines page, it's showing you the cost of those medicines. So you have here basically an ordering list in the first section, and you have a budget for them in the second section, or a pricing list for them in the second section. That is basically all of the cost sections in the tool, apart from some that I'll come to in a moment, which are these dark blue ones over here, which are providing with intermediate calculations. The tool also helps you to calculate the impact by using a different tool produced by Johns Hopkins, which is called LIST, which is the Lives Saved tool. And the instructions for using the tool are in this sheet, and then there are tables that you can fill to calculate the lives saved, but using formulas and data that LIST has. If there are questions on this and we have time, then Colin is the best person to answer this, because he's used it much more than I have. So this would enable you to start preparing your investment case by saying the program will cost X, but we will save a certain number of lives with that investment, making a good case for getting the funding for that investment. This is not populated, but it would be populated in a complete example, and when you use it. Here are the definitions for LIST. So this whole section allows you to calculate the list. It's not populated in this example. Another section here is some guidance on how to do something called a bottleneck analysis. So when you set the targets for scaling up the numbers of services, you need to take into account if there are some bottlenecks that would not be resolved as part of the community health worker invention. One example could be if there's a shortage of medicines because of procurement issues at the national level, or because of distribution to the regions, this community health work program is not going to solve those. So you need to identify those bottlenecks or those constraints for two reasons. First of all, because it may limit your targets. You may need to set your targets lower than you would like to, on the one hand, but this also indicates if priority should be given through other investments by donors or by the government to resolve those bottlenecks, because on the grounds that the community health worker program cannot achieve its goals if these bottlenecks are not removed. So this is something that's not done within the tool, but there is a guide on how to do it within the tool, which is in this sheet. And in the user guide, there is more information on how to do this kind of bottlenecks. The remaining sections of the tool here are those intermediate calculation sheets. I'm not going to go into them all. They're very detailed, but if you wanted to look at the demography calculations within the tool and just get more information on how they're all being calculated, these are not data entry sheets. These are just telling you what the tool has done in more detail than is shown in the results pages. So you have demography, you have the supervision, you have the numbers of community health workers, the package of services, etc., etc. Summaries of the standard treatment guidelines, which is a very helpful place to go and look to see, how many minutes are being used for each service. You can see, for example, that pneumonia treatment has 55 minutes of the community health worker time. You could start to look at that and say, is there a way in which that time can be reduced without reducing the quality of the service? So this kind of helps you to look at the constituents of this. And that is really the tool, a quick overview of the tool. As I mentioned, for people who are interested, there will be some follow-up training on the tool. And what we will do with that is we will provide a case study, which will then require the participants to take the case study and add some information into the tool, change figures within the tool, etc., etc., and learn how to use the tool by doing it, as opposed to listening to me explain how the tool works. So more information on that can be provided. So I'm going to try to hand over to Colin now to just finish the PowerPoint, and then we will have time for questions.
Thanks, David. I hope everyone can hear me. And I hope I can give you a break from speaking for a bit. Nice to see some of the questions coming in the chat. Please keep them coming. If you don't mind blowing that up, David, or maximizing.
Sorry about that.
That's all right.
Joe.
So in preparing.
Okay. Oops. Hold on.
So in
there we are.
Preparing for this presentation, David and I were both reflecting on some of the common challenges that we face, and probably some of you have faced in conducting costing or using this tool for scenario planning. We were reflecting on some case studies from, as David mentioned, Burkina Faso, Madagascar, Sierra Leone, Malawi, among other countries. So we put together a small list, not exhaustive. I think the exhaustive list can be found in some of the challenges and limitations sections of each report. But maybe I'll just run through a few of them as you embark on your own costing. Now on the first bullet, for at least retrospective costing of CHW programs, it's really essential, as David mentioned, to obtain details on the number and types of services that CHWs are actually providing or have provided in the previous years. Ideally, having data on the number of populations, their catchment size. And with this data, we can actually measure things like the cost per service, the cost per capita, total cost of the program. But as we know, and I think reflecting on John Barazzo's comment in the chat, obtaining data from health information systems, particularly at the community level, is really challenging. And I think in some ways, health information systems at the community level can sometimes undervalue the contributions of CHWs. What's captured in terms of outputs, like diarrhea cases treated, malaria diagnoses and treatments, it probably undervalues their contributions in more promotional services, being present in their community more on the promotional side in terms of, for example, WASH, sensitization, et cetera. So without this data, though, in terms of outputs, it can be really challenging to understand what they're capable of providing. We often see complete fragmentation in reporting. For example, in South Sudan, when we conducted an investment case of their Boma Health initiative, it was really impossible to obtain compiled data at the national level for community health workers. It was all disaggregated and fragmented by implementing NGO partners. There was no national database at the time of on data on community health worker services or interventions. So without that, it's really hard to have a baseline cost of what CHWs have provided in the past. On the second bullet, as David mentioned, when we lack baseline data on the number and types of services that CHWs are providing, it really, again, gives us little indication of what they can achieve in the future. It's hard to get an estimate of what CHWs can deliver if we don't know what they've delivered in the past. So for prospective costing and planning, we often find that working with ministries of health, particularly community health units within the ministry, some targets can be overly ambitious, sometimes perhaps unattainable, again, unless we really understand what CHWs have provided in the past and what some of those supply and demand side bottlenecks are inhibiting the achievement of those service targets. On the third bullet, as David kind of walked us through on the tool, normative costs really give us an indication of what the ideal resource needs are if services are being provided according to some sort of norm or high quality standard. But commonly, it actually probably in all cases for country case studies, we found that these standards aren't necessarily defined in the way we need them to be for national CHW programs. So for example, David walked us through service norms, like how long it should take to treat a case of diarrhea, for example, which includes, seeing a child, diagnosing, treatment, referrals if needed. And that data is really challenging at the country level to identify in terms of time, often very challenging in terms of lacking standard treatment protocols sometimes as well. But other key questions were asked is, how much time should CHWs be spending on their actual job duties? How much time should supervisors be actually spending on their job duties? Other key questions we ask is, where should services be provided? Is it at the home of the patient, or is it at the home of the CHW, or within the community? And knowing these assumptions can really help us better understand, how much time available CHWs have and whether they are being, over or under committed in terms of the job duties that are required of them. So while this isn't an exhaustive list of challenges, they're definitely some of the more common ones that we face in using the tool for costing and planning purposes. Next slide. So this tool is, oops, just going to put something in the chat. This tool is open source. If I can find where to put it in the chat, there we go. I'll include the link here. Oops. Let's see, I'll put the link in here. The tool is available in English and French. We also have some brief orientation webinars included in the website, introductory videos, and links to all of our country reports and investment cases that at least MSH has done. There are others out there. in terms of reports and investment cases that I think Dianess might have a better handle on. Also included is the handbook, which walks you through in detail some of the aspects or modules that David had referred to in terms of using the Live Save tool for investment cases, aspects related to bottleneck analyses, et cetera. So it is open source, it's open access, but we do ask you request it through the email address there. We like to track our users, so in case there are future updates to the tool, we can push those updates out to you and also provide you with new resources. So feel free to access it on the link and request it via the email there. Over.
Oh, thanks, Colin. So this is just a list of the acknowledgements that people who were involved in developing the tool, both the first version and the second version, and also the people from the countries where the tool was used who very kindly provided us with feedback on improvements that should be made for number 2, for the second version of the tool. So I think that's the end of the presentation. So I guess the next step is to go to the chats and see what questions are included there. This is not something, this is not one of my greatest skills, so you'll have to be patient with me, but Colin can also dive in. I'm looking down. Am I looking in the right place? Okay.
I can try to maybe moderate if that's okay.
Oh, please do. Thank you.
So I'll start from the top. Dr. Janet from WHO Afro is interested in knowing more about the assumptions that inform the urban versus rural modules. Also, she was not sure if she saw health promotion, growth monitoring, and other interventions included in the IMCI, community IMCI. I can try to take that.
Please do.
So we found when updating the tool to version 2, we found that within countries, even though they had a national CHW policy, we often found some kind of separation or more specific, I would say, job duties for urban CHWs versus rural. I'm trying to recall a specific case study, but we found in general some of the urban CHWs were tasked mostly with promotional services, education, sensitization, and referred all curative services to local primary health centers. However, at the among rural CHWs, those CHWs were tasked with not only promotional services but also curative, given geographic distance barriers to local primary health centers. So that's why we decided to separate, having the flexibility and ability to have multiple cadres of CHWs. We also see cases where there might be more female health workers specializing in family planning. So that's just, I think the example that David provided was more illustrative, but we do have that flexibility in the tool if there are specific packages that urban and rural CHWs are providing. I think the same for your question on health promotion, growth monitoring, and community IMCI. Again, this is just dummy data. This is just illustrative, but the users do have flexibility to really tailor service packages to country needs and explicit service packages that have been defined. I'm not sure if David, you want to add to that?
No, I think that's fine. I think just to mention on the urban versus rural, you might have the urban community health workers who, because they have less travel time, they can actually provide more services than the rural ones. So that's another way that it can be useful to separate the two groups.
I'm going to maybe try to answer a couple questions under the same theme. I see RS asks, do you include transportation costs? Elizabeth asks, you don't include surveillance and registration and service package. Again, I think the guided tour that David provided us with is really, using illustrative data. But one of the aspects of the tool that I particularly like is its flexibility. You can adapt it to country context. You can adapt it to service packages. So, for example, while there might not have been a specific line item under transportation costs, we've included that in the past. It's, for example, monthly transportation costs for CHWs to commute from their place of work, place of home to the local primary health center. And that's something that's easily able to include. The same goes for the service package. We have provided built into the tool some existing kind of norms and standards of what maybe a illustrative package could look like, but really the intention is to adapt that at the country level to the standards that have been defined.
Colin, maybe I can answer John Barrasso's comments and you can jump in. Hello?
Great.
Yeah, Colin?
Yeah, go for it.
Okay. So thanks, John, for your question. First of all, on the issue of the confidence in the inputs and how much confidence we therefore have in the outputs. I think that is a very important point with this kind of analysis. And I think we have to, as we're doing this work, we have to recognize the uncertainties around the inputs. And we have to look at what the impact is that of these uncertainties are on the outputs. Some of them, for example, if there's an uncertainty around the price of a medicine, it may have a very small impact. If there's uncertainty on the travel time of a community health worker, it may have quite a large impact on the outputs. So I think measuring that and including those in the report that you produce when you've done this work is very important so that people have an idea. However, it's been our experience over the years that not doing this kind of cost modeling because the inputs are uncertain is probably a mistake, because when you conduct this kind of study, it does help you identify what those uncertainties are. And as I said, on how much impact those uncertainties have on the results. In other words, how important they are and what kind of priorities are needed to try to make the data, the input data, get more accurate input data. So I don't think we ever assume that the model is perfect, although there is always a danger, as you say, that when you see something that produces these perfectly calibrated figures of $3.49, you assume that they're quite accurate. Of course, they're not. They are still estimates. So I think that those people who use these tools and people who are presented with the results, they must recognize the uncertainties and what those uncertainties, what the impact of those uncertainties is. Second question, is it more useful for scenario planning? I think it's or for generating an investment case. I think it's important for both. I think for me, I think the first one is very important because the scenario planning, a typical example, well, Colin can speak about this, but South Sudan, for example, and some of the other countries, Colin, please add after this, after I've finished, that they come up with a program for community health workers, which will not be financed. There just isn't enough money from the donors or from the government system to finance it. And therefore, meeting those ideals for the community health worker program are not realistic. Then it's where you get into the scenario planning, which is basically how do we reduce the community health worker program in a way which you can still achieve good outputs, that you can use the limited resources that you do have in the best way possible. And you do that to fit the amount of funding that's available. So it's really the planning function of the program. I think the scenario planning is absolutely crucial, because I think in many cases, programs are developed or plans are developed which are over ambitious, and then they can't be presented to the donors or the government because they won't accept that they're realistic. So I think scenario planning is very important. And that also fits in with the second question about generating an investment case. An investment case, I think the basis for the investment case for me is, first of all, that it is realistic in terms of what can be achieved given the bottlenecks and with the funding that's available. And then the part that supports that is obviously the lives saved and the other information. There is an additional type of analysis around the investment case, which I think we think is important, which is also looking at the impact on costs. So, for example, if you are providing a service at the community level as opposed to at a health center, you can be saving funding you can be saving money from the health center perspective, which they can then use their resources to do other things. But you're also saving money from the patient perspective, because they don't have to travel to a health center to get a service. They can get it in their community. So I think it's good to look at the life saved aspect, but I would like to see more research done on the actual cost savings to both the program and to the patients. So I think, as you say, it's both of those are really very important features, and that's a good comment. Colin, did you want to add on that? So, for example, South Sudan.
Yeah, I think you've summarized it well. Maybe just to add that the tool is very dynamic in nature. So you change a unit price of a medicine, as David mentioned, and the entire costs are going to change. It's great for these kind of what if scenario analyses. Building off what David said in South Sudan, we've also used it in the past to answer questions. What if we introduced a new service to the package of CHWs? What if they begin to, for example, conduct pregnancy tests, or they add family planning services onto the existing package? I think the big question in this community is, what is the impact on total costs if CHWs actually receive salaries or payments? And we can conduct those scenario analyses to see, how these policies are going to impact the total costs and resource requirements of a program. So I think in my opinion, that's probably the best use of this tool. It's to see, the impact of these small changes, but we can really assess, how significant the changes are on the cost of the program. So it's really dynamic. And once you have the model kind of built, you can start playing with some of these assumptions, as David mentioned.
Are you going through the others, Colin?
Right. Start from the bottom. So Samuel asks, are we collaborating with other donors or partners to promote the use of the tool? I know there are colleagues from UNICEF on the line. This actually was developed in collaboration with UNICEF. It's been used in over a dozen plus countries. So we continue to see interest, particularly from past country use cases. It's really the ability to update your modules and assumptions for future planning and resource allocation. Elizabeth Berryman, there are requests to digitize CHW systems to improve data for action. Does this tool help to analyze this? And as these programs are very expensive. I'm not sure how to exactly answer that. I don't know if David, you want to provide any insight or thoughts?
I'm looking for the question because I didn't completely understand it. What, can you repeat the question?
Sure. Elizabeth asks, there are requests to digitize community health worker systems to improve data for action. Does this tool help to analyze this, as these programs are very expensive?
It does. I don't think this program itself helps to analyze that, but it would help you to look at the impact on the costs of doing that within the context of the program as a whole. Yes, because you can include the digitization costs as part of the general package costs. And so you could see if it increases your overall cost by 10% or 1% or 20%. So that would help you make a case for digitization, I think.
Samuel asks an interesting question. Samuel says this tool is valuable for facilitating implementation research and planning and budgeting for CHW programs. But when should the tool be employed in your intervention timeline? After completing the testing phase of your intervention? Question mark.
So this I have very strong feelings on this. With regard to all of the tools, and Colin and I have worked on tools for costing health centers, TB programs, malaria programs, hospitals, etc. And my immediate thought is you should start off using a tool like this in parallel when you're doing the planning. So as soon as you start to plan a TB program, or you start to plan a community health worker program, you should have the tool immediately open, and you should be populating it with your assumptions, your planning assumptions. Otherwise, you get down the common track of producing a plan for something that's not being costed and is not going to be feasible and is not going to be approved, and it will not happen. So I'm not sure if I interpreted the question right, but that is the intervention timeline for me, which is doing it right at the beginning of the whole planning process. Colin, do you want to add?
Yeah, I think that's, I would also say, we've used the tool in the past where, there's a national policy in place. But really, again, it's first scenario planning. How can we evolve and improve upon what's already there? So, for example, if there's updates to required training modules, we can begin to include those assumptions into the tool. If there are changes to the service package, if there are changes to financial incentives, we can again embed those assumptions into the tool to conduct scenario analyses.
I think when people develop the packages of services, both for community health work programs, but also for primary health care, the people who develop the packages almost never look at the costs of providing those services. So it's quite common to have packages of services which are pushed as being essential services for the public, without there being any idea as to whether they're affordable or feasible. And then what happens is, you have services that end up actually not being provided. This package of services, in a place where only 50 or 60% of those services are actually provided, even though the government has promised them, because there isn't the money, there aren't the resources to carry them out. So even at the early stage of developing a package of care for community health workers or for other primary healthcare services, example, costing should be done then. So at the earliest possible stage for me, it should be done. Thank you.
David, this isn't a question, but maybe a comment that can be converted to a question. In the chat, Jane Briggs says this is a helpful tool now, given the current funding opportunity through the Global Fund for ICCM, including platform costs and non-malaria commodities. Do you want to say anything just about how the tool can be used for example, understanding, specific costs within the package. So for example, those tied to ICCM programs or those tied to family planning programs, et cetera.
Thank you, Jane, and Colin. So, I mean, from the beginning, when we were costing ICCM and when we were costing, because the precursor to this tool was an ICCM costing tool that we developed and used in quite a few countries. So even back at that stage, we didn't limit the costs of the ICCM services to those which were funded by the Global Fund. We felt it was absolutely essential to show all of the costs of providing the services and then use that as a basis for making the case for funding those additional medicines that were not covered, non-malaria commodities in this case. So, so I think the broad aspect of this is that you shouldn't, it's a mistake to only include in the costs of a program those which have available funding. That's a terrible mistake. You have to include the costs of everything that is required to make the program work properly, to provide good quality of care to people. And then you use that as a basis to go out and get the money or to advocate for the money that are needed. So I think, Jane, we've been trying to do that all along, and it's great to see that now the donors have stepped up on these non-malaria commodities. Thank you.
See another question from Michelle, who asks, in planning for services and the human resources to provide those services, CHWs are not the only providers to be planned and costed. Does this tool take into account the increase of other health workers in the country and districts?
I mean, the answer is no, because that would require a more comprehensive planning, almost like a district level planning for services, which is even though it has been attempted in the past, it's too complex at the moment to deal with that. When you're working with the kind of norms for different levels of care, be it from community health workers to extension workers coming out from health facilities to health facility services at 3 or 4 different levels of health facilities. It's too complex to do that at the moment without massive kind of research and resources. So it should take, I do think if you're planning community health worker program, you need to look outside the program to see where are these services currently provided. So if it is the diagnosis and treatment of malaria, you need to be looking at where are these services currently provided? Are they provided in health posts, health centers, hospitals? And how does the community health worker program fit with that? And if you are task shifting basically from a nurse in a health center to a community health worker, you need to figure out how that's going to be done, obviously with good quality, and what the impact then is on the nursing services provided in the facility. So I would say to do it within the concept of the overall package, and then to put package costs together for different levels of care, it's probably too complicated. We have played around with it, but it's really quite hard to do. But I would look at that in the planning of the community health worker program to look at how the human resources fits within that. And it also applies in a way to the medicines, because there may be sufficient medicines in the health centers to provide a service which you are now shifting to the community. You don't need to buy additional medicines. You can transfer those medicines out of the health center. So I think looking at the impact when you're planning a community health worker program, looking at the impact probably on a service by service level, partly anyway, on the next level of care, would be an important thing to do. A very good question. Thank you.
I think we've covered most of the questions. Some may have also been answered just in our catch-all responses. Sita, anything else?
No, nothing else from my side, just that I put in the chat to please indicate if you're interested in any follow-on training in the tool by emailing us. And I put that address link right there. And if you'd like to receive the tool itself, Colin also put that email in the chat.
Good. So shall we call it a close then? Sita, is that okay?
I think so, unless any other participants have questions that haven't been resolved. Maybe we can open the floor and people can unmute themselves and ask a question if they have one.
Sure.
Okay, if not, then thank you so much, David and Colin, and thank you for all of your excellent questions, everyone.
Yeah, thanks everyone. It's been great, and appreciate all of your questions and comments. And if there's interest or further questions, I'm sure you can send them to the Alliance, and will be forwarded on to us, and we'll be happy to answer them as best we can. And you've already received the note about the additional training. We will probably need to limit the numbers of people in that training. So I think, and it will involve work on behalf of the participants. So we'll be happy for people to join that. But you should probably take it as a fairly serious commitment in order to conduct that training, because there will be time needs on the part of the participants. So thanks very much, everyone. And bye for now. Colin?
Thank you. Bye-bye.
Thanks again.
Yeah. Okay.